Okay, this is part 4 of the assessment 5.2 for the musculoskeletal system. And we are going to continue with the legs and the knees. First thing we're going to do is just do the inspection of the knees. Let's see, we'll have you extend one knee. Bring your leg out, there you go. Okay. And we're going to just observe it for its natural concavities on the front, the sides, and above and below the patella. We're going to observe bend his knee and observe the landmarks in the patella and all sides, and palpate it for any type of crepitus, any redness, swelling, and note all the major landmarks. I'm going to palpate the tibial femoral joint to make sure it's smooth and firm, no tenderness. Already said no nodules or crepitus. Palpate the tibial tuberosity and the popliteal space. So it's tender?
Yeah.
Okay. He does have a little bit of tenderness. He does have some trouble out of his knees because of his scoliosis from his back and his external rotation of his hips. Hey, baby, watch out. Me through. Patients to be able to stand, and then you would observe his lower extremity alignment. You would note the angle between the femur and the tibia, and it should be less than 15 degrees, which his would be more than that. As far as knee range of motion, he's not really able to do this, so I'll illustrate this. You want to bend the knee toward the back, if I can even do it, at 130 degrees. And then you want to check for full extension, which is straighten the leg up and lift. It should come up off the floor at least 15 degrees for the extension. And we want to, then we would repeat these motions and apply opposing force. James is not, come here. He's not able to do this because of his balance issues. Okay, come here. Here we go. Leave off. So as far as motion against resistance, we would do these motions again. We would flex and then apply resistance. And then we would bend and not allow anyone to push down or straighten. And then we would also straighten the leg and not allow anyone to push down. Okay. As far as the hips and pelvis, let's see. Can you stand up?
Yeah.
We're really supposed to have a patient loss of pine, but that is not ideal at this time. You gonna be a helper? You gonna help him? So you would have your patient license upon and inspect and palpate the hips and the pelvis. You would notice any instability or tenderness, crepitus.
Right there.
Yeah, tenderness. Check the range of motion of the hips. As far as hip motion, which he's not able to do this anyway, laying supine, but he would line supine. You should be able to lay the leg straight up and over the body. The hip flexion should be 90 degrees, left and right. You then lie him prone on his stomach, and he would be doing rear leg raises with the hyperextension to be 30 degrees. supine, the left leg should come straight back, and the right knee should come to the chest at 120 degrees. Hip flexion, abduction, swinging the leg out, should be at 45 degrees, and adduction should be at 30 degrees, swinging the leg across the body toward the midline. Internal rotation is bend one knee up and keep the other leg straight and lift it up off the bed, and that should have a 40-degree angle. Then relax and return to neutral position. Let's see. As far as external rotation, you would put the right ankle on the left knee and bring it up the front side of the leg and allow it to fall to the side, and that would get a 45-degree angle. And then you would repeat this also with the hip flexion against resistance. You would bend your right knee, apply resistance. Are you able to do that?
Right knee.
Yeah, can you do it? Right knee, apply resistance against the hip and knee while it's bent. To test the hip extension, you would, with the straight leg out, you would push it, lift it up off the bed and try to push it down, and patient would meet resistance that way. Hip abduction, you let the leg fall out from the body and don't allow to push in. Hip adduction, let's see, you would pull the leg away and not allow it to be pulled away from the midline.
Yeah.
Okay, feet and ankles, you would also, for the feet and ankles, you would, feet and ankles, you would observe the patient's gait. You would want them to walk back and forth from the wall, which, let's see, can I do that? Can you sit down?
Yeah.
If she'll let me. She don't take it away from me. Put your leg over here. Just put one foot up here. Okay. We're going to check to make sure. We're going to check to make sure that the surface is smooth, that it is rounded malleola and prominent heels on the metatarsal phalangeal joints. We're going to check the longitudinal arches, which he does have some lowering of his arches due to his external rotation, and then also due to weight issues, increased BMI. And he does have to wear some arch supports for that. He also has are you helping? Oh, he does also have just a slight foot drop, which is he's underwent therapy for, just because of his paresthesia of his back. And that causes him to have quite a few frequent falls. And with the weakness that he experiences, his knees often give out from underneath of him. So you can check the longitudinal arches, and you should be able to bear weight on the midline of the heel between the second and third toe evenly. And with your patient seated, you can note that he has no deformities. He has all 5 toes. He has no redness or swelling. He does have a duck and a bear. You can check the Achilles tendon. Well, the tender, I'm sure, where he walks externally rotated. The anterior surface of the angle, and then the medial and the lateral malleolus. We will also use the thumbs and the fingers to compress the metacarpal, metatarsal phalangeal joints. We're also going to, you can check the range of motion from where you're sitting. Dorsiflexion. Yep. Dorsiflexion. Dorsiflexion should be at 20 degrees. Plantar flexion, put your foot down. Down toward the ground, it's at 45 degrees. He is able to turn his foot inward, inward for the inversion at 30 degrees, and then for the eversion at 20 degrees. And I think that concludes the musculoskeletal system assessment.